if you're into this kind of dentistry. We're going to use case studies, examples, again, for full arch, veneer, and anterior implant crowns, because I think those are three different areas that are completely different from one another and have distinct nuances to making really great stunning provisionals. So each one has its own unique challenges and things that will make your life easier that I could share with you. I'm also going to tell you about an incredible offer to work with me directly with your cases for the next 12 months after today. So that'll be after we look at these cases. Then we're going to have a question and answer session. So if you'd like to ask any questions by typing in the question area, that's great. I'll try and answer as many questions as possible during the question and answer session. And then I added last night a bonus implant presentation, and today when I made it to the office, because this was a non-clinical day, I was working on the teaching material. So today I was working on my teaching material. I was working at my home, but I had a case that I wanted to add even when I came into the office today that was on my consult room computer. And so there's a little video there. I think you're going to really like it. We actually have 3 different cases I'm going to show in the bonus implant presentation. One of them is a video of what I call a surgically guided vertical sinus lift. So I'll explain that procedure to you and show you a little video of that. It's pretty cool. So I think you'll like that. That's at the end of the presentation. I saw a patient that I seeded an upper arch of restorations for 2 weeks ago. So she came in because we had to treatment plan an implant for her upper right first molar. When we started her case in the summer, she needed clearly an extraction on the upper first molar. So we had the option of doing that, letting it heal, placing the implant, then starting the rehab. But she wanted the rehab started before that because she had some issues with a number of other teeth. So we did the rehab without the upper first molar, which now we're going to make fit with the rest of the rehab. And the rehab was an upper arch minus the upper first molar on the right side, and 4 different restorations on the lower arch. She wasn't ready to do the whole lower arch, which was fine. I could make it work with 4 restorations. There's one other filling I need to do. Ideally, some gingival grafting. But overall, this will make the case work. So she came in. We were going to take final bite records of the lower restorations against the finished upper, because I like to segment the finishing of cases. And we were doing a final consultation about the implant that needs to be placed. And it happens to need a surgically guided vertical sinus lift. So that will be something that I'm doing in 2 weeks. So we're going to do the surgically guided vertical sinus lift. The point of all this is I want to show you after 2 weeks post-seeding the restorations what the tissue looks like. So I took these pictures with my new Nikon D850 camera, which is super high resolution. We're still calibrating the exposure on this. So I believe I underexposed these a little bit, but they still look pretty good. Now, if you look really close up, the tissue's really healthy and looks very good for 2 weeks post cementing of the upper restorations. So there's no black holes anywhere, no gingival embrasures that are blown out, no real significant inflammation anywhere. Tissue just looks good, healthy, and nice. So why does this happen? Number 1, we have good, well-fitting restorations that are cemented properly, and you've cleaned the excess resin cement, because these are bonded porcelain restorations on the anterior. They're feldspathic layered jacket crowns that are essentially like feldspathic veneers. They could be Emax crowns too. I've bonded these like veneers. There's 6 anterior restorations. The posteriors are zirconia cemented with a resin ionomer type of cement, but the anterior are weaker but prettier feldspathic porcelain that has to be bonded like a porcelain veneer. So you have to really control the cement cleanup and the finishing of the margins. Now the margins, finishing the margins and cleaning up the cement, I use mostly hand instruments because I don't want to damage the porcelain. So that is just another presentation altogether. If you look, the other significant key to getting a result like this 2 weeks post-placement and not having, blown out papilla and black triangles in the gingival architecture, the other significant key is the provisional restoration and the contours of the provisional restoration and the fit of the provisional restoration. And this one obviously was pretty good because the tissue is pretty damn good at seating. Now, let me show you when I took the provisional off. So here's provisional removal, immediate provisional removal 2 weeks ago. So that's pretty good. And that's what I'm looking for. Look at the peak of tissue here. This looks amazing. And the tissue's healthy over here. There was a point in time when it was a little inflamed, so we managed that. And there are some issues that you want to avoid having with your provisional restorations. Number one is lots of gingival inflammation for your seating appointment. Number two is blowing out papilla. So there's a lot of things that we do to make sure that we don't have that happen. I'll show you that with contouring of these. And when I have a long-term provisional case like this, I really don't want leakage. There's a small leakage right here, tiny leakage here. Everywhere else, there's no leakage. It's all nicely sealed, and the tissue looks good. So this is Duralon used as a provisional cement. So it's a polycarboxylate cement. It's really a permanent cement, but I use it as a provisional cement for my cases when I know they're going to be a few months. So this was a provisional cement for this case. And this particular provisional cement, you need to essentially remove it with a sonic scaler. So I sonic scale it, but I get great tissue results around it. So you can see here, after we sonic scaled and tried in the case and verified everything was good, we micro-etched the preps because this case had resin buildups in a number of places, composite resin buildups. So I had to micro-etch the preps to prepare everything for bonding because I want the surface clean of the preparation and I want the buildups micro-etched. And so look up the tissue really close up after micro-etching and cleaning of the provisional cement. And the tissue looks really good. So this is what we want. We don't want to blow out the papillas and we don't want tremendous amount of inflammation everywhere. So I seeded the case. This was the picture from 2 weeks ago. At seeding, you can see there's a little cement on the tissue here and there, but I've cleaned the cement carefully, interproximally at the margins, again, generally with hand instrumentation. This is the one class 5 I still have to restore, although it'd be nice if we did some grafting first. For the scanning, we do a Simplant plan and surgical guide. So I'll talk about this at the end of the webinar when I show you my guided surgery vertical sinus lift. But this is planned for a guided surgery vertical sinus lift. It's an odd planning because of the way that I do this, but I'll explain at the end of the webinar because it's interesting. So here's her before and after. It's pretty darn good, really. This was why she wanted to get started right away. She was starting to have teeth break because she wore down her anterior guidance. So she was on posterior group function. The 1.6 had an endodontic treatment a couple of years ago. It was never restored and it fractured. She actually came to see me about 2 years before I did her case. She was referred by a member, came to see us. We gave her all the estimates and she wasn't prepared to go ahead with the case at that point in time and came back, I think, when it broke. And said she was ready to go ahead. She didn't want to experience any more breaking of teeth. And we were able to start the case. So we're at a good point in the case. We're going to finish the lower crowns that we're planning. They were in provisionals the whole last 2 months as well. It's just I didn't want to finish upper and lower at the same time. So we let her function with the upper crowns to the lower provisionals the last 2 weeks. She said everything's excellent, so we went ahead with the final bite records for upper restorations against the lower preps. So I had to take off the lower provisionals, obviously, to do that yesterday. And so that's all good. Now, if you look at her before smile. This is her before smile. This is her after smile from yesterday. It's a pretty dramatic improvement. The only other things that could improve her, and we talked about this, is ortho on the lower arch to improve the lower incisors and some gingival grafting. But for the most part, it's a pretty darn big improvement in her smile. It's a big improvement in her smile. And if you look at her full smile, she looks like a different person. It's amazing what we could do for our patients. They could look, I told her, you look easily 10 years younger, maybe more. It's incredible how much better people can look when we restore their smile. Not to mention all the occlusal benefits when you look at her lack of guidance when we started this process to restoring the occlusion, taking the back teeth out of the path of destruction. So she hopefully won't break as many more back teeth as she would have if we left her like this. She has a lot of structurally compromised teeth. So I don't know that all of these restorations in the posterior are going to last the rest of her life. But we've given them a better chance because we have the guidance on the cuspids now. And we will make her a bite splint once the implant is placed and the crown is placed and the lower restorations are done. Because I think she's a nocturnal buxer. I'm not 100% sure, but I think it's highly probable. So, big improvement for this patient's smile. And I'll tell you, it is a lot of fun to do this kind of dentistry. It's really what I enjoy doing in my practice. After 25 years of practice, it's really what I mostly just want to be doing now. And if you look at what you do in your practice, what you like, what you don't like, I'm increasingly decreasing the things that I don't like to do in practice and increasing the things that I do like to do. And I'm focusing most of my time on the things that I do to do, which is a luxury you can have after 25 years in clinical practice if you've set up your practice over the years to be the way you want it to be. And that's what I did consciously probably a little over 20 years ago. So what I want to say, though, is that everyone here tonight can do this kind of dentistry. I truly believe this. I believe that beautiful and precise dentistry is not just for the gurus. And this isn't just me saying this. I believe this. And I know this because I've helped other dentists achieve this kind of results as well. So excellent provisional restorations are obviously critical for getting excellent results with your more complex cases. So with that in mind, we want to talk about fabrication, testing, refinement, verification, and approval. And we're going to look at full arch, veneer, and anterior single tooth implant crowns, crown provisionals. We're going to start off the presentation looking at full arch, a full arch case. And then we'll go to veneer, and then we'll go to some implant cases. So as far as fabrication is concerned, we'll look at my full arch case that I wanted to share tonight. And the critical part for fabricating provisionals for me is we have to have an excellent diagnostic wax-up. That is critical. So first thing we need is an excellent diagnostic wax-up. Then what we need is a duplicate model of that diagnostic wax-up. So my ceramist, Harold Heindel, waxes the cases up according to our treatment planning and our force management checklist and our diagnostic wax-up instructions. So Harold waxes these up. He makes duplicate models of the wax-up and sends them to me. I have my team make the different putties and the different stents that we use to check the preparations and to verify the preparation depths and then to create the provisional restorations. On occasion, I will use the putty Harold used to create the duplicate model of the wax-up to make the provisional restoration. But I find I don't love using putty to create the provisional shell form. I prefer using a clear stent. So we can get excellent, really highly adapted clear stents by using a machine called the BioStar. There's also a mini star, but they're a pressure forming machine that is significantly more accurate than a Stavac machine. And the material that we use is hard cast, and it's made by the same company as the BioStar, and it's made to use with the BioStar. So we're using hard cast 0.8 by 125 millimeters. It's a round disc. The copyplast we use to put the holes in it, and I use this as a depth reduction evaluator. The hard cast is the harder one, stiffer and even more accurate. We make 2 of those because sometimes I don't like the provisional or the shade and I want to make another one, so it's good to have 2. And we also make a seating jig out of triad. Well, it used to be out of triad. So here's one of the hard cast shells on the duplicate model of the wax up with the seating jig. And that helps me seat a full arch provisional when the entire mouth is prepared. So BioStar machine, hard cast material. We do, for all of you Occlusion Design members who joined us tonight, we do have in Module 5 a fabricating preparation putty and stents video that my assistant and I made. And it shows her making the putties, the stents, and the guides. And I'm filming it. So that's a good video for you and your team to look at to learn how to do this. I'm going to teach with a clinical video of making a full arch provisional for a case I did in the winter. So I'm going to teach using this tonight. So let's look at this particular video. Okay, so what we have is, this is the patient. He had some previous old restorative dentistry, also needed some buildups, and he actually needed crown lengthening as well. So we're seeing him at the point where I've taken off the old dentistry, done the core buildups, and we need a provisional restoration. And we're going to use this to start testing the new occlusion design and aesthetic design for the case. So we're changing his occlusion, changing his aesthetics, and just taking off and cleaning up the old dentistry. That's step 1. We're not doing a final impression this day. The tissue's not ready. We're thinking of placing an implant in the edentulous space. We have to do crown lengthening on this side. So there's quite a bit of dentistry still to do before we can finish the case. But during all of this dentistry, we need a provisional restoration. And you can have a lab fabricated provisional restoration, but it's really not necessary. I've been doing cases, large cases like this, for over 20 years, and I've largely only used this kind of provisional for over 20 years. So let me show you the video. So we're putting Vaseline on the prepared teeth so that the provisional doesn't stick. I have not created a full arch here that draws. So I'm going to seat an entire arch shell and provisional, but I haven't made the preps so they draw. That's not in the cards. We would over prepare the teeth. I'm just going to use the technique I use with this to prevent it from locking on. So there's a technique you can follow. So this will not lock on, and it's all good. So the preps don't draw, just so you know. So I'm filling up the shell. This is the hard cast shell. You can see here how accurate this is. We've left a lot of the palate to help with seating, and the buccal, we've left as much of the gingiva as we can to help with seating. The nice thing about this is I can see clearly as I'm seating it that the margins are lining up. So that's an advantage over the putty. And the other thing is I can have an easier time of preventing it from locking on, which you'll see in a sec. So here's the jig. This is a seating jig to make sure it's seated all the way on both sides. There was one thing preventing that from our wax up, which you'll see on the first bicuspid on the left side. You can actually see a perforation when I take the jig off. So I'll explain that later. So I have this seated all the way. I've used the jig to make sure it's seated as evenly as possible. We have a perforation here. So this is actually maybe not seating quite as well here because Harold had waxed this up, this bicuspid, to be more like a cuspid, because he's missing, the patient's missing his natural lateral. We're making this cuspid look more like a lateral and this bicuspid look more like a cuspid, which I think was a mistake because it's a structurally compromised tooth. I didn't want to over prep it here. So we needed to actually wax it up with more like a bicuspid a little bit. So I seeded this as far as I could with the idea that I just add to that, not re-prep. So let's watch a little bit more. So at this point, the material is starting to set. You can see on the perimeter where it's extruded, it's starting to set. So if I leave it on till it's completely set and don't touch it, it may lock in because there are undercuts from prep to prep to prep because it's not meant to draw except for where the bridge was. But what I'm doing now is I'm loosening it before it fully sets. So it has to get to that kind of rubbery state of set with the material. It's ProTemp Plus, by the way, but Luxatemp works just as well, any of these materials. So I get it so it's over here, the extruded amount is rubbery, and then I start loosening the shell on the teeth, on the prepared teeth. And we rinse a lot here because honestly feel like it's, even though I know these materials don't heat up as much as a PMMA material, I honestly feel the heat coming through the shell more than not. So I like to rinse it. Plus, we're using the rinse underneath the shells as a lubricant. It's just water so that I can get this on and off so it doesn't lock on. So I'm trying to loosen it a little bit without taking it all the way off. So we get a good fit of the provisional that's reasonable, but it's still loose. So it's kind of a loose fit, but it's as good a fit at the margins as we can get. So we want a good marginal fit, but loose kind of in the body part of the provisional. So we're just loosening this here. You can see we're going to rinse. We're going to rinse under the hard cast shell. And this is not tight against the preps now because I loosened it slightly. It's on the preps, but it's not locked on tight because it probably would get caught on the undercut. See here, I'm loosening it and I'm rinsing underneath. This allows for less heat, obviously, although that's not as big a concern as with PMMA. But what this does is it's allowing me to be able to get this on and off easily. So I want this to fully set on the preps, but loose on the preps in a loose manner, if that makes sense to you. So this is what we're doing. When we let this fully set, it takes a few minutes, but this helps me in the end. I will section this provisional into 3 sections, so we don't need perfect draw from, say, the right molar to the left molars, but we'd like it to have the ability in segments to be able to go on and off. I don't want to make all of these as individual units, and one of these is a bridge anyway, but I don't want to make this all individual units. The other issue with these is they can be a little hard to get out. So as you can see here, you'll see exactly how I get it out. I end up cutting the shell in multiple places to get it out without breaking the provisional. So this is the other difficulty with these kind of shells. Difficulty number 1 is be careful not to lock it on your preps, which is easily managed by starting to take it off when it's in the rubbery phase. Difficulty number 2 is getting it out of the shell. So here you can see I'm cutting the shell in multiple places, and then that gets the shell so that it has a loose fit on the provisionals, and the loose fit on the provisionals makes it easier for me to just pop the provisional out of it. You'll see it'll pop at some point next little bit. And you can see there's hardly any flash anywhere except for where the provisional got a little held up by the perforation in the palatal cusp area of the first bicuspid on the left side. Everywhere else, the provisional seated beautifully. So if I didn't have that one area holding it up, I think this would have literally no flash, which is great. Less trimming time needed. So you can see I'm using an anterior sickle scaler. Just pop this out. You learn just to be a little careful with this. I don't prepare teeth really deep, so my provisional shells are a little thin sometimes in places. So with that in mind, I have to be careful also. So now we could take this thing entirely out. Being a little careful there where it perfed, because that might be a weak point. And now it's pretty easy to fix the perf. I'm just going to add flowable composite to that when it's seated in his mouth. You can see how good this looks right off the bat. There's really not a tremendous amount of trimming to get the provisional ready to go into place for the patient. So here we're going to seat this. It's really nicely. I could take it on and off, even though it's a full arch that's not really drawing. And what we're going to do here is we're definitely going to add. I'm not going to prep that down any further because the tooth itself is somewhat compromised. So when you take it out of the shell, if you don't clean the surface aggressively with alcohol, you can add without even adhesive or adhesive resin. So I can add flowable composite to this provisional and it'll stay. It's not a problem at all. You could light cure it. Now the only thing that we have to do is just make sure that it's not an occlusal interference when we finish the lower arch provisional. And I usually do these in consecutive days. So this was a full mouth case. I did the upper one day, the lower the next day. And these are pictures when we did the lower. So you can see here's the shell, really well adapted. Here's the triad resin jig that I used to help seating. Here's the material. Apparently it's discontinued, or at least it's discontinued in Canada. So here is what we're using now. It's called DuraSplint LC from Great Lakes Orthodontics. It's again made by the company that makes the BioStar and the hard cast shell material. I'll tell you, I don't love this material. It works as well as the triad, but it's really got a thick oxygen inhibition layer, so it's sticky. You have to really cure it a lot. We cure it in the triad oven, and it still doesn't feel as nicely cured as the triad material. The triad material was actually a provisional material, but it cured really well in the triad oven, and even with a photopolymerizing light, but it has a tremendous exotherm, this material. This is not a material you would use intraorally. It's just tremendous amount of exotherm. It's the hottest material I think I've ever felt when it's curing. So you do not want to use this intraorally. You could use it on an indirect provisional technique, but the techniques I'm showing you today are direct provisional techniques created directly in the patient's mouth. So let me show you another clinical video of trimming that particular provisional. So let's look at this. So here's the sectioning of it. I'm using a VisionFlex disc from Brasler. I need to section it mesial of the cuspid in one side on the right side because the first bicuspid's a pontic. And on the other side, I'm going to section it, I guess, distal of the bicuspid. I'll have to see what I ended up doing there. This is an odd case. We got a pontic on one side and we have a lateral on the other side that's really a cuspid. So I believe I sectioned it on the cuspid. So here you can see here, yeah, I sectioned it. Ended up sectioning it distal of the central. So I have a little 3-unit piece here, and then the others are posterior pieces. So let's just show you, though, a couple of details here. So when you cut this, just show you this. So I'm using this disc. I want to section my full arch provisional into 3 places. So you notice I cut into the contact in multiple places. So I'm cutting into the contact with this thin disc. As soon as I cut into the contact enough, so in the gingival floor and then into the contact on buccal and lingual, it's thin enough now that I could break it. So all I do is break it. I don't cut all the way through because then you'd have an open contact. So I just break it. So see there, we broke it, and here's the other one. Once again, cutting through, broke it. There we go. And then for the flash that we do have, we don't have a tremendous amount of flash, but the flash we do have, I generally trim this almost exclusively with Softflex XT discs. I find this is the best thing to trim this material. Works really well. You can see here, we're just trimming this. And I don't know, because I do this all the time, I'm so used to it that I can trim provisionals really nicely and quick, really, with the XT discs. Here we're just trimming. Now the embrasures, the XT disc can get in, but to get that beautiful embrasure form so that you don't blow out the papillas, you sometimes need to go in with something even thinner. Frequently what I'll do is I'll try the Vision Flex discs, but the newer ones I find are thicker than the old ones, so I don't love those. So I'll go in with a Mosquito Diamond or a 7901, some kind of really thin, high-speed rotary instrument. Diamond or carbide will work, and just thin out the embrasure form with that. Once I've got it designed with the carbide or the diamond, the thin instrument, I'll go in and finalize it with the XT discs. So particular attention needs to be paid to these gingival embrasures. Right there, that's not refined enough on either side. I need to get that even better, or I'll blow out the papilla. Very, very important. You can see how I'm going in there, but I wouldn't say that that would be enough even. I'll go in with a thinner Mosquito Diamond or a 7901 and make it even more defined there. So this is the Brasler Vision Flex disc kit. The old ones on the straight lab mandrel, they were thinner, and I haven't found any more of those. I keep ordering different ones and they're too thick. We used to get these really, really thin ones that I could carve the gingival embrasures just with the Vision Flex disc. The problem was they'd get destroyed so easily. I might get 2 provisional carvings out of them and then they'd be destroyed. So these ones are more robust. They don't get destroyed as easily. They're good for sectioning provisionals, but I find they're too thick. The disc is too thick for embrasure form. So I've had to adapt to using a 7901 or a Mosquito Diamond and carve the embrasure form. Then go back with the Softflex XT discs. So here are the XT discs. These are the Mylar backed ones, so they're flexible. They carve and trim really nicely. And then I'll polish the provisional with all of these discs. And then one thing that we do on some cases is we coat it with a glaze. So this is a glisten it's called, from Clinician's Choice. It's a provisional resin glaze, and this works nicely. I find that it doesn't fully cure as well unless I put it in the triad oven. I find it has a little oxygen inhibition there as well, which I don't like. So we put the provisionals in the triad oven, and that does the trick. Another thing that I do, on some cases, I don't want to glaze. I've tested different types of polish. So this is a polish we use on a lathe with just a felt type of wheel or different types of wheels. And so we'll polish the provisionals that way, and we don't even have to glaze them. And then the materials we use for cementing, I'm typically using Cling 2 instead of Temp Bond, and it seems to work quite well. So we've used that as our regular cement. The case you saw earlier today, I knew it was going to be a few months, so I used Duralon. And it's a polycarboxylate cement from 3M-SB, and it's very strong. It's basically a weak permanent cement. It's strong for provisionals, though. Strong for provisionals. I don't routinely use it for single unit provisionals because there's really no need. The cling works well, especially if it's going to be a case that'll turn over in less than a month. But for cases that are going to be 2, 3, 4, 6 months, this becomes a better choice. Now, the case that you just saw, here's the lower arch. For that case, we fabricated the provisional in one piece. You can see that one, we didn't have any places where it held up. So this lower arch provisional is actually out of the mouth, hardly any trimming. It was quite fantastic. Now this one we sectioned distal to the second bi, or the first bis, but the anterior is more veneer-like. So if you look here, actually the bis are veneer-like too. So that's why we sectioned it that way. So the first bis were more veneer-like here as well. So you can see all these are veneer provisionals, which I'll talk about more in a few minutes, and crown provisionals. And we put the floss in between the embrasures so we could floss it out after and prevent. The other thing is cement from getting in the embrasures. So you could carve the embrasures beautifully, but if you get a whole bunch of cement in there, then you're asking for blown out papillas as well. So that's not good. Now testing, what we want to do is we need to test the new occlusion and aesthetic design with the provisional restorations. This is a big part of my protocol, is that we have a provisional evaluation appointment. And on the smaller cases, like an 8-unit veneer case or 8-unit anterior crown case, for example, we'll typically only need one provisional evaluation appointment. At that point, we take records of the provisional, photographs of the provisional, pick the shade, take shade photos, do everything that you need to do. But on the larger cases where we're altering the vertical dimension, the anterior guidance, the overbite, the overjet, we'll typically have a couple of provisional evaluation appointments. My typical provisional evaluation appointment is 2 weeks post-provisionalization, but there are some cases where we'll see them the first week post-provisionalization, and some cases, depending on travel schedules of the patients, etc., might be 3 weeks. But typically somewhere in between 1 to 3 weeks, we want to see the patient back, evaluate how everything looks and feels, and then decide what we're going to do as far as going forward. Are we happy with everything? Do we need to change something? Is everything the way the patient wants? Is the occlusion the way that we want? And that's really some of this aesthetics is subjective. Some of the rest of it is pretty easy to tell. So refinement is the provisional evaluation appointment. At that appointment, we decide there's something that needs to be changed. And frequently it's the patient who tells us. So you look at this case, patient had tremendous erosion and attrition on his teeth. He's been used to really short teeth for a long time. So he had issues when we made his teeth longer, making F and S sounds. So we had two things to think about here. One is the F sounds are typically the teeth are too long for this particular patient. So we shortened the provisionals. So you can see here, he felt they were too long. So we shortened them. They were still quite a bit longer than what he started, but they were a little shorter than ideal, which was what we were trying to achieve. But ideal aesthetics doesn't always equal ideal function or comfort for the patient. So number one was to adjust the incisal edge position for the F sounds. Number two was the S sounds and the comfort he felt on the palatal contours of his restorations. He was really eroded, and the really eroded patients, if you add a lot of palatal and cingulum anatomy, they frequently don't like them. So Harold had built some nice anatomy, but the patient couldn't tolerate it. So the S sounds were largely from the palatal contour. So I had to flatten and kind of hollow that. From the lateral views, you can see the shortened aesthetics looks pretty good. But the other thing I felt was we could build the teeth just a little thicker facially. I wanted to at least test that because I had underprepared the teeth because there wasn't a lot of tooth there to prepare. So I felt we need to leave the preps where they are for the structure of the teeth, and let's just make these 4 incisors a little thicker because you can kind of see my preps through the provisional. And because I was going to adjust the palatal contour, my thought was I'll adjust the palatal contour And then I'll make some new provisionals for the incisors because I want to test out making them thicker so I don't have to prep the teeth further back. So I just had Harold take the adjusted model of the provisionals and add facial contour to it. And I felt that this would give us what we're looking for. For aesthetics, would still be reasonable as long as his Fs were okay. And I wouldn't have to prep the tooth too much more because there wasn't a lot of tooth there anyway. So you can see as before teeth, there's not a lot of tooth there. And we did some crown lengthening, but still these teeth are structurally compromised. So Harold made beautiful palatal anatomy, but there was too much anatomy here for him. He's used to this. So we had to go much flatter with the new palatal anatomy. It was just too bulky in the cingulums. So you can look at what I changed it to with the provisionals, and he felt much better. There's no pronounced cingulum here. It's closer to where he started. And, if he had ortho on the lower incisors, which we talked about, but he wasn't interested in, we could have brought the lower incisors into a better position and maybe those contours could have worked. But where his lower incisors were and where he was used to, that just didn't work for him. But we were able to get everything right and then take the new, make the final restorations. So again, testing this out, refining it, and then testing again. Once we get approval, we can make the final restorations, and here's the final upper arch. It looks pretty freaking great. But it's more functionally comfortable for the patient. And here's a couple other views. And now the tissue isn't perfect here, I will admit, not like the first case. But what happened was, while we were in the testing phase of the provisionals for this patient, he got sick. And so he had cancer and he was undergoing a lot of procedures. So his oral hygiene did suffer. And, sometimes with chemo, you get some issues. Very, very nice patient. Unfortunately, he passed away. And very sad, very sad. But, pretty much a drag. He found out when we were in the testing phase, it was over the holidays. He found out he was sick and had some back problems. Found out it was very sad. So his high oral condition, tissue-wise, isn't as perfect as the other cases you'll see because he had some systemic issues. But, he did end up with chemo and everything living. It must have been another 1.5 years after diagnosis, maybe 2 years. And then he kind of got sick quickly and passed away. So we had seen him a few months before and he was pretty good. But the nice thing was he was able to do a fair bit of traveling while he was under the treatment. He was able to travel quite a bit in between treatments, and he had some good quality time the last 1.5 years. So that was nice. Anyway, kind of a sad story. Everybody is touched by cancer. Every family, everywhere. That's just the way it is, unfortunately. It's really quite terrible. So another case I want to share, another case with some bad tissue before we started, obviously. And you look here, these are the old restorations this patient had. I did not do these, I will say, but it's pretty much old restorative dentistry that's kind of beat up. I did actually replace these ones over here. These two, I think, I did replace at one point because they were breaking. And I said, let's do the rest. Finally, he came in and said, okay, I'm ready to do the rest. We have the wax up completed. And then we make the preparations, make the provisionals, have them come in for a provisional evaluation appointment. At the provisional evaluation appointment, it's pretty clear. The right side is a little long. It's a little long. So I can see it now looking back at the provisional on the wax up or the wax up. It's definitely too long over here. I can see it right here. It's just canted. And it matches in his mouth. So it's canted, not quite right. He actually was like, hey, I love this. Looks great. I'm happy with it. When can we do the finals? I actually, he was late for the appointment. It's kind of a funny story. Late for the evaluation appointment. Came in, said, I love it. Everything's good. when could we do the finals? I said, okay, well, we'll take the records quickly. You're a little late, but I'll take the pictures. We'll have Amanda take some models, and we'll pick the shade, and I'll send it to Harold. Next day, I'm looking at the pictures and the models, and I'm like, shit. Obviously, it's not good to be rushed, because clearly this is wrong. I need to adjust it. So we called them and said, we have to alter this. It's really off. It's off enough that I can't kind of figure it out just by changing the provisional model. So we had them come back in, and I reshaped it a fair bit to get it level. So this is now level and looks good. He, I guess, after that said, yeah, I guess I can see it now. Not everybody notices canting. I didn't notice it immediately either. I should have picked that up. But again, he was late, got stuck in traffic, came in. We're like, okay, how is it? I'm like, okay, we've got to finish. It's just life, right? But I did catch it when I was looking at the pictures about to send it to Harold. So you could see the difference between the canted side and the adjusted and refined side. It's pretty significant. So that is something we definitely needed to do. Definitely needed to do that. And so these images and a new temp model were sent to Harold to make the case. And the case happened to be an Emacs case. I do a lot of feldspathic cases, but this case we decided to use Emacs. And it's a layered Emacs on the facial and monolithic everywhere else. And Harold can make some nice Emacs. So again, this was the prep appointment, impression, solid model. Harold's trying to make it so he doesn't have any blown out papilla. And you look at this. This looks pretty damn good at the seeding appointment. So that's, I think, maybe a couple weeks after seeding. If you look at the before and after, the tissue health has improved significantly. He does have some papilla issues here around this tooth. But we got it much healthier with the provisionals because this wasn't fitting well. And it's much healthier at the 2-week post-seeding appointment. And it looks even better now. I would venture to guess. I don't think I have a post-op of it. Well, I probably do because he's been in since. I should dig that up. So here it is again, before and after. We did some laser gingivectomy before I started in the planning phase. And I also did a laser curettage of that papilla that was not looking good. So you can see here it was very inflamed. So I did this ahead of time, let it heal for a few weeks, then we did the preps and provisionals and tried to just get the tissue better and better as we were going through managing the case. And it does look quite a bit better here. And my guess is, based on the way tissue responds to well-fitted porcelain, this is probably just a little bit better on each of these at this stage. See, these two were splinted at some point because they broke. And this one wasn't fitting well. You can see the margin gap. So that's why the tissue isn't perfect here. But it's much better here, and I would guess that it's optimal now. I'll have to dig out the pictures. Verification and approval. Probably not a bad idea to have the patient sign saying that they approve the shade that you're going to build the case at and approve the incisal edge position and anything else that needs to be changed. They could write it on the sheet. So some form of approval for your provisional restorations is a good idea. Same with seeding your final restorations. You should have some form of approval for that. And we made these that we have for our members. This is my approval form. And so with full mouth cases, as I've said, we finish the full mouth cases one arch at a time. So we then test more by testing the finished arch against the provisional arch. So that gives us further testing and refinement and further opportunity to take new records that will be even more precise when you go to insert the final arch of restorations. So here is the case we showed you earlier with the lateral that's a cuspid, the bicuspid that's a cuspid, or made to look like a cuspid, and then we had placed an implant over in the edentulous pontic area. We finished the lower arch. You can see the lower arch here, and we're testing the lower arch to the upper provisional. This was actually off a little bit at this stage. So what happens is this provisional now was probably, 4 months old at this point, maybe 5 months, and I'd taken it off a couple times because I took it off a couple times to do crown lengthening surgery on this side, took it off a couple times to do the implant over here. I think it was loose here. You'll see where it's cracked in one of these photos. This case had some refinement to the case. I added length to this case. You can see the flowable composite where I added the length. I added a little bit of incisal edge position. But overall, it looks pretty good. If you have provisionals that are in the mouth for even 2 to 3 to 4 to 5 months, depending on the patient's diet, they can get stained. You can see the staining on this one. It was pretty close to the end of its rope at this stage. So when I took the final restorative records for this case, I did make them a second set of provisionals. Because as I said, this one was pretty much at the end of the rope. We tested it, though, against the lower finished restorations. So the lower is all zirconia restorations, finished. You can see the lower arch finished. It's funny. This is funny. My hygienist, who's very experienced, saw these restorations for cleaning, because we had them in for cleaning before the seating of the upper. And she's like, he wore through the crowns. I can see dentin on the incisal edge. And I'm like, what? So I went in the room and I said, that is something Harold did to make them look natural. It's actual wear simulated in the porcelain. I'm like, he can't wear through zirconia crowns. There's no way. He is a big bruxer, I think, and he has a lot of bite force. So I did have a little flutter of my heart when she said that when he was in for hygiene. But yeah, he fooled her with this cool ceramic. So you can see here, this does look like wear into dentin. But Harold did that intentionally because the patient told us, he's in his 60s. He said, give me natural looking aesthetics, nice looking aesthetics, but natural looking. So we did a little characterization. So here you can see, taking this off a few times, I ended up breaking it. So it broke here and it broke kind of over here too. So it broke in a couple of places. So at the records appointment here, I decided we'd make a new upper provisional for him. But you look at the case, again, after testing, finishing the case one arch at a time, crown lengthening surgery, letting that heal, implant placement, letting that heal, guided implant surgery, that is. After all of that, I think we were at 6 months of treatment time, maybe 7. Somewhere in the 6 to 7 month range. And we were finished. So you can see his finished case. Turned out really nice. Very natural looking aesthetics. Looking here at his before and after. Nice looking aesthetics considering, again, we started with this cuspid here and a large space. Bicuspid here that was quite structurally compromised and had an endo needed crown lengthening. A lot of issues here, kind of a peggish lateral. So it took a lot to get this aesthetically better. We did talk again about ortho, but he was not interested in ortho. I even thought, geez, we can take out this bad bicuspid. It's not a great tooth. Move the cuspid back and place an implant here. And I told him that's a great plan, but he didn't want ortho. He'd still be an ortho. He's now finished. So I can respect that. So here's the finished case. He's already had some staining in a couple of areas that will come off of the porcelain, though. This is all zirconia restorations. They're all zirconia layered in the anterior, full contour zirconia in the posterior. Here is a close-up of the case. Great tissue health. No blown out papillas anywhere from my provisionals. And we were able to test a significant change in the occlusion design for this patient and aesthetic design with the provisional restorations and determine that my provisionals were not quite long enough on the centrals. We wanted it a little bit longer to make the final restorations. These are the little aesthetic details that you want to figure out with the provisionals so that you could get the aesthetics dialed in for the patient. So here it is here. Here is the final upper close-up. Here's before and after. Pretty significant change. We decided to use zirconia here. They're full contour zirconia on the palatal right up to the incisal edge because we have a fair amount of unsupported porcelain, so we didn't want to use feldspathic. In this particular case, I felt it was too much unsupported porcelain with a bruxer with high bite force. We did make him a bite splint post-treatment for protection. This is his E-splint protection and helps to deprogram his muscles if he's getting a lot of stress. He will not clench and grind quite as much with this type of appliance design. This was designed for my mentor, Dr. Jimmy Eubank, who's a brilliant clinician. So we actually buy the splints from his lab. He's created a lab to build these. We get our CR splints from him, and we get our E splints from him, pretty much all our splints. And I'm in Canada. I send them to Texas to get them because it's the best that I've had for the most part, compared to, unfortunately, just getting it locally. Plus, Jimmy has the patent on the E splint, so I respect that. I will buy it from him. So next is provisional veneers. They have their own issues with provisional veneers. The issues with provisional veneers are getting them to stick. And the more conservative your provisional veneer or your preparation for veneers is, the more difficult it is to get the veneer provisional to stick. So we have to use a different material to cement the restorations. The fabrication is similar to what I just showed you in those videos. I use the hard cast shell. I carve it with the XT discs. I use the Vision Flex discs. It's almost the same idea. The difference is in the cementing of the restorations. I can't use Duralon and get it to stay. I can't use Cling 2 and get it to stay. I have to use something different, and I have to change the technique. So the technique that we used for many years was using a material called Neotemp. And for Neotemp, I like this material. It's easy to handle if you're used to cements. It's easier for us as clinicians if we're used to cements. The disadvantage is with really thin veneers, and I'm getting more and more thinner veneers with cases because we prep less and less and get into virtual no prep cases. If we want to provisionalize those, we have to go to a different type of cement deal. So with normal thickness veneers, I would say that this Neotemp technique is really nice, and it's more familiar for us because it's a cement. So let's look at this. I'll show you a clinical video of this. It's an older one, but it's still a really good video. So here it is. Case I did 12 years ago, roughly. Here I'm just injecting some of the ProTemp Plus in around the margins. Probably didn't need to do that, to be honest with you. It's a 10-unit veneer case. Patient had some diastemas, so we've got some spaces. Otherwise, we're prepped very conservatively. But the diastemas, those spaces actually help us with retention, so that's not a bad thing. And so I'm seating my shell. Same technique again. We take the provisional out of the shell, the hard cast shell, and then we're going to trim it with XT discs. So you can see how thin my preps are. I haven't prepped them really aggressively. I'm going to trim the excess more or less on the palatal with scissors, and then the XT discs. So the XT discs are what we want to use for this. I do almost the entire contouring of the provisional with the XT discs. Now, here's an interesting idea. If he doesn't have a deep overbite, if he has a shallow overbite, you can leave some of this flash to help you with retention. But if he has any kind of deeper overbite, you can't, because it'll interfere with the ability to close. But sometimes I cheat and leave some flash for that, or have it waxed to leave some flash beyond the margin of the provisional only, obviously. So here we're contouring the embrasure form. XT disc is really good. We can get a lot of it done with just this. You can see how thin the provisionals are because, again, I didn't over-prepare his teeth. And the patient's not going with a really, really super white shade. It's a dentist not going with super white shade, so we're able to do less preparation thickness, thinner veneers, if we're not changing the shades so much. So here's the technique. With the NeoTemp, I spot etch, so a small amount of spot etch, and then we gluma desensitizer, some form of gluma type of product to desensitize and kind of kill the bacteria around the margins, and it keeps the bacteria killed generally for most of the provisional phase. Then we're going to seat the provisional loaded with the NeoTemp. I've got lots of NeoTemp here, so you'll see how it extrudes and how it cleans up. The one thing I did with this case is I put some adhesive resin on the etched areas. I'm not sure you need to do that, and I don't know that I'd recommend that anymore. It makes it harder to get off. So this was 12 years ago, and it was a dentist I was treating. I did not want these coming off. So I put a little adhesive resin where I etched. I'm going to micro etch that at seating, so it won't still be there, but it does make it harder for you to get the provisional off. So I'm not sure I'd recommend the adhesive resin step. And for the next provisional technique, absolutely no adhesive resin is what I would say. So here it is here. We've rinsed and dried the area where we etched. Here we're now placing the desensitizer. It's an antibacterial solution of gluma, the glutaraldehyde type of solution. This is not the gluma adhesive. It's just gluma desensitizer, or G5 from Clinician's Choice. So now we dry that. And here's the step that I would say you probably shouldn't do. Unless you're doing veneers on your mother-in-law and you want to make sure they don't fall off. I would probably not do this step, which is adhesive resin. So I don't know that you need to do this. Here's the filter on my scope because we're putting a little adhesive resin on here. Now maybe do it on the bicuspids. The bicuspid veneer temps, when they're not prepped much like this, are hard to stay on. But I absolutely didn't need this on the laterals or centrals because we have extra retention from the diastema, because the margin of the veneer provisional goes to the palatal. So I am putting this here. Again, not sure we really need that, but I guess it didn't hurt. So that was Optibond FL adhesive. We're going to cure it. And here is the whole 10-unit provisional in one piece being seated with the NeoTemp in it. The NeoTemp's kind of a white opaque material. The beauty of the NeoTemp is the way it peels off once it gets to a rubbery phase. So we let it get to its rubbery phase. We have it seated. We have the floss here so we can take it out of the embrasures where we opened the contact, where there were contact space. And look at this. It's very nice to clean up. It gets to a rubbery phase and it peels off nicely. So that's the advantage of this. If you used that much excess cement with different material like flowable composite, it would be a disastrous mess. So here you can make sure it's fully sealed the preparation. You could have excess. As long as you peel it off before it fully cures, it comes off really nicely. And so we've had good success over many years in many cases using NeoTemp. It's slightly less retentive than the next technique I'm going to show you. So with thin veneers, I don't find this as ideal. But these are thin, but not ultra thin. You know, the newer veneers, some of them get really thin. These are probably 0.6, 0.8. These veneers, you can get less than 0.6. Then your veneer provisional is so thin. It's kind of very hard to manage. So here, if you look at this, we're flossing out the embrasures. Again, you could have good contour of your embrasure, but if you leave a piece of cement in there, you're going to have issues with your provisionals and issues with inflammation, and then ultimately issues at the seating appointment, trying to seat your restorations. So here I'm spending time making sure I get any excess off. And that's that. Here is the 10-unit provisional. It's quite a nice little piece of art there. Here is the really thin Vision Flex disc here. This is the ultra thin one. And I don't know, haven't been able to find that in Canada at least. Here's a thicker one. Again, these thicker ones, not thin like this. I can't get the embrasures quite the same. You look at this one. I could carve embrasures in a beautiful way with this. It was quite the instrument. Just got destroyed easily. So again, you need embrasure, and what I'd like to see is a little space above the papilla with my provisional, because the papilla has been retracted a little bit in the impression appointment if you've done the impression and retraction that day. So we want space for it to rebound. Even if I didn't do the impression, I still want a little space, because you want room for the papilla to rebound if it needs to and if it can. So here's the provisionals a few weeks later at the provisional check appointment. You can see it looks pretty good. He has a little ulceration on his lip, maybe from all the work. Not sure, but the shape, contour, everything about the provisionals was good for the most part. It was quite good. So to get these off with this NeoTemp technique and the next technique that I show you, what we end up doing is I section them, and then I use a crown spreader. So this is a Brasler crown spreader. We section and use the spreader. So I have a video of this from the case that I just showed. So I might as well show you this. So here's the case at seating. We're going to section, let's let it play. We're going to section the provisional with a thin diamond. I usually use a KS0. And you want to be careful not to section into the prep and prep the tooth again. So NeoTemp's really good for this because it's pretty white opaque, so you can see it as you're thinning out the provisional. It's not too difficult. So here we are, we're thinning this out. And now what I do is I just kind of break the provisional with the crown spreader. Now I haven't thinned it out as much as I could here. I need to thin the incisal edge a little more because that's all provisional. But basically you cut and thin and then torque it with the crown spreader and it'll pop off. You'll see this one pops off. So that whole section popped off. Here on these other two, I would, and I'm sure in the video I had to, I will have to cut the incisal edge short of the prep, obviously, and just spread it that way. But overall, here's the case. Again, dentist had ortho first. They redistributed the space because of his diastemas. Here's post-ortho, looks pretty darn good. And then we had Harold do the wax up, one of the few that he did in white wax, which is surprising. Here's the duplicate model of the wax up. Here is the porcelain restorations. 10 units of feldspathic porcelain made in a natural aesthetics with translucencies and characterizations and just natural aesthetics. Here he is with provisionals to the final restorations. Let's go back to that. So the provisional determined the new incisal edge position, overall aesthetic design. Tested of refining and adding to the guidance as well. But look at the natural aesthetics here. This looks really terrific. Another dentist that I treated, by the way. Here he is before and after. I think looks pretty darn good. And his befores before ortho were even worse. I should pull those out one day. I think I have them. I think I saw them before ortho when we took pictures. But they're probably slides because this was long enough ago that the case was probably started before ortho when I was still in slides. So here's the before and after close-ups. You can see all the characterizations in the porcelain and the luster of the porcelain, just kind of a lower kind of matte, kind of satiny finish. Looks really nice in person. We wrote an article for the AACD journal about this case to share with the journal back in fall 2006. I can see on the looking closely at this. So this case must be then, maybe it's from 2014. I thought maybe 15. So this could be 13 years old now. It's in that range. He's doing well with it. It's somebody that I see because he's a classmate of mine, friend of mine. So this was a nice case, nice write-up for the AACD journal if you wanted to Google it. Biomimetics and conservative porcelain veneer techniques guided by the diagnostic wax-up diagnostic matrix, and diagnostic provisional. And so here's another provisional veneer that I did more recently. This is coming out of the mouth, so you can see the flash that needs to be contoured off. You can see the inside view. We have left a little flash for kind of retention purposes beyond the margin where the occlusion wasn't going to be in the way. And then here, if you look at the carving of the embrasure form, you can see how carved this is compared to here. So we carved that pretty significantly. And then you can see this one was glazed. I can tell that it was glazed. I'm trying to think of which case this was. Oh, I know who this was. I was just trying to remember. But you can look here, you can see how much the embrasure form was carved. Very important to spend a lot of time thinking about the design of the embrasure form and getting it right. And then another example where you can see how I've overlapped. This was a crown and then veneer provisionals. It's actually the case I'm going to show next. But we overlapped a couple of areas just to try and get more retention. And that helps. As you can see, the veneer provisionals are pretty, but there was a crown here too. And then this is a 10-unit veneer provisional I did that I shared with my members. This was no real overlapping available because of the way the occlusion is fairly tight, but nice provisional veneer. Here's the frontal view of that veneer, and this one was glazed as well. You can see the embrasures all carved pretty distinctly. Funny thing with this, I used this image for some ads for a webinar, not really a provisional webinar, just for a webinar, just because Facebook doesn't let you use imagery that shows teeth, just plastic teeth. So I could show plastic teeth outside the mouth. I could show porcelain teeth outside the mouth, but I can't show teeth inside the mouth, even though that's what would be more interesting to the target audience of dentists. But I used this picture. Somebody said, "Why are the margins so bad on your porcelain veneers?" And I'm like, this isn't the porcelain veneers. This is the provisional. It's a little gappy because we're seeding it with flowable composite. I'm not worried about that. But my margins aren't like this, and my final veneers don't have margins that look like this. But it was funny. I must have had 3 comments in different occasions like that. They actually thought these were the final porcelain veneers. And then the one guy said, "I was wondering how you got them to all stand up like that." I'm like, dude, it's the splinted provisional. It's not the veneers. And then I thought, geez, next time I use one of these images for a picture, I better spend some time smoothing the margins, even though it doesn't matter because of the way these are seated. So this technique is the flowable technique. So I'm going to seat the restorations with flowable composite resin, and I'm not using neotamp. So this is even more retentive, and it's great in one way because it's more retentive. It looks nice. The fit and finish of the provisionals is great. The problem is getting them off. It's even harder to get them off than the neotamp, and it's a little harder to manage when you're seating. So the neotamp's a great technique. But a case like this where I have no real overlapping, where I have provisional bicuspid veneers, where there's no retention, I haven't prepped through any of the contacts. This is a truly non-retentive provisional veneer. I prefer the flowable composite because I'm used to it now and I get better retention on these cases. This case has more retention than the other case. I could use neotamp on this case and I would feel pretty good about it. This case, though, I did use flowable composite. As it got to the point where in my practice, I'm like, okay, I'm now really used to the flowable composite provisional technique. Do I need to use the neotamp? That's the question. And it expired and we didn't order more. I'm still debating after looking at that video earlier whether or not I should bring it back for some of these more retentive veneer cases. It's definitely better if you have a crown and veneers, a combination of, say, crown, veneer, veneer, because it's much easier on the crowns. When I cement something like this with flowable composite over the crown as well, it's a trick to get it off. That's the difficulty. So it's great if you have a non-retentive provisional veneer, or if you have really thin provisional veneers, it's difficult to remove. So that's why I wanted to share with you both techniques. The easier technique to manage is the neotemp resin cement technique, or resin provisional technique, than this, what I'm about to show you. But this works well. You just have to be really careful when you're seeding the provisional to clean up all the excess cement from the embrasures. So let's look at this. So this one I spot etch as well. The difference with this one is we have no adhesive. Absolutely no adhesive for this one. This is a bad idea. You'll never get these suckers off. So no adhesive, just spot etch. Gluma desensitizer, load the provisional with flowable composite, and seed it. And then before you cure it, because it's light cured flowable composite, it's not setting, so you don't have a rubbery stage. Before you cure it, go in and remove the excess from the embrasures. In fact, what we do is I tack cure it like I do with final porcelain veneer. Sorry, I was moving the scope, I think, and it shook a little on this video in a couple spots. So here we're loading it. And we have lots of excess flowable composite. The good news is if you don't get light on it, you have as much time as you'd like to remove the excess. The bad news is you have to remove all this excess. Now, I could have maybe had floss here. That might have been better. Right in here, floss there. Where I don't break the contacts, though, I can't really have floss on veneer provisionals because it won't seat through the unbroken contact. So there was one there I could have maybe put floss, maybe two. But here we are. We have the distinct potential here of blowing out papilla because we've got too much flowable. I probably put too much flowable in as it is, but it's better for you to see this than not enough flowable. If you don't have enough flowable, you can get lots of leakage, so you have to put enough in. But I've got so much in here, my embrasures are all getting blown out if I leave it like this. So I have to manage this. So I'm using a brush to get it out. If these were final veneers, I'd be using a rubber tip. But with provisionals, I want to use a brush. So I want it out more aggressively, so to speak. So here I'm just removing it now with the Explorer as well. And then we're going to hold it down, and my assistant's going to tack them with a tacking tip on my 3M light. So that we tack it for 1 sec, each one, and then they'll stop moving. So I'm holding, she's tacking. This will not cure the composite in the embrasures. So this now gives me a chance to clean up the embrasures again. You can see there's excess here. I can now clean up the excess. They're not moving around. They're tacked in place. And the flowable composite veneer cementing, provisional veneer cementing, the key is the excess. And then the second key is getting them off. So it's harder to get them off. You have to section it more diligently and use that spreading instrument. So here we're going to cure it a little bit more. And then I know I'm going to have a little bit more embrasure to remove, embrasure cement to remove. There we're using tape so we don't bond adjacent teeth. You can see, before I cure this fully, you want to really go through and remove the excess. Excess over here to remove. So it is a little more difficult than the neotemp. If you want something a little easier, go with the neotemp. And once it gets rubbery, it just peels off. This is more difficult. It is more retentive, though, also. So that's the good thing, to outweigh the couple of bad things. So once you get used to it, it's a pretty efficient technique, but it does take some time. You can see there, I'm going to remove a little bit more from the embrasures. Use the scaler, explore. Then I just smooth that so it looks nice. Just some flowable composite being added. Got a little in the brazier, I have to remove that. A little bit of work here, getting this just right. So hopefully that was fun. Does everybody like seeing clinical video? I think it's helpful to see video when we do these kind of trainings. So here are the embrasure forms. You can see this is that case you just saw the video on. Looks pretty darn good. And this was after a couple months also in provisionals. So you can see all these blue things are like a breath stick thing they use. I was wondering for a while what patients were coming in with. And then one of them showed me. But the embrasure form and the tissue health looks good here because of the time we took at seating. So here it is after I remove the provisional, the day I'm seating the case. Tissue looks pretty darn good. I haven't blown out the papillas. And here's the case before and after. Before provisionals and after. Looks pretty darn good. And close-up of the final after like a little bit of healing. And here it is at 2 years post-treatment. Looks pretty darn good. I just saw this patient this week. He was in for hygiene. Looks great. Looks great. Really nice color. They're bleach 4, but they look really good in his smile. They look great in his smile. So let's talk about implant provisionals. So with dental implant provisionals, there's a couple of things I want to point out. Let me show you this case. This case is a case that needed the tooth extracted. She had a lesion in the root, and we could have, you could have erupted the root and had more ferrule, but the bottom line was there was an endodontic lesion here. And she didn't really want endosurgery, so the lesion dictated the tooth had to come out. And the endodontist didn't think he could retreat it conventionally. It would need surgery. So we decided to remove it. The tooth was kind of dark and gray too. So we removed it. I grafted the site. I'll share with you the grafting at the end of the webinar and the bonus implant training. But we grafted the site. I let it heal. No immediate implant. We wanted to let it heal. Gain as much tissue as we could. We let this heal for 3 months. I sent her for a 3D x-ray. We were able to plan out the implant positioning and basically placed the implant through a tissue punch. Here's the tissue after provisionalization of the grafted site. So I had a provisional on the graft right here. Basically, I cut her crown off and bonded it to the adjacent teeth. So the crown that came off when this tooth fell apart, I cut the post off of it. I polished it really well, and I bonded it after this extraction and grafting. So it was bonded to the adjacent teeth. So that's that. And over the course of the 3 to 4 months, it developed a socket that looked like this, or a grafted site that looked like this. Look how perfect this looks. It's freaking amazing. So I punched the tissue, placed the implant through guided surgery. Here's the implant placed. Get the platform to the correct depth, which is critical in the anterior aesthetic zone. Something we talked about with the members in August on the member webinar, showing them how I'm determining the platform depth. And then we test it with the Austell. So the Austell ISQ gives me a resonance frequency analysis of the implant. If the implant is above 75, I'll consider a provisional crown at implant surgery, so immediate provisional. And it was, so we decided to make a provisional crown. So in the anterior aesthetic zone, I like screw-retained provisional crowns. Even if the screw hole has to come out the buccal, I don't care. I want screw-retained provisional implant crowns because it's going to give me the best control over the gingival level aesthetics. Easiest to take on and off and adjust. So here I'm contouring my provisional abutment to look more like a custom abutment. So I'm contouring it, and then I put all these retention areas in the custom provisional abutment. So this is a provisional peak abutment. That's contour and trimming, contourable, I guess would be the word. Here's another one for an NC. This one was an RC. Different types of bone level Straumann implants. We have our copyplast shell with depth holes. I'm able to check the prep depth and space around this contoured abutment. So I've trimmed and contoured the abutment. I'm able to check that. Here it is in place. I know that this abutment will not be near the surface of the facial of the provisional cranium. So what we do is the access hole is going to come out the palatal incisal. I fill the access area and the screw. It's covered by plumber's tape here, or Teflon tape. So I've covered that with Teflon tape so the provisional doesn't get down there. You could even leave a little bit of it out so it's easier to find, but it's generally easy to find. So we're going to now take our hard cast shell, fill it with ProTemp Plus material, and seat it here and let it completely set. We don't try to take it off in this instance. We leave it on to completely set and shrink wrap around the provisional abutment, which has a lot of retention form in it. You could even micro etch these if you want. You could even add Optibond adhesive or some kind of adhesive to it. The one issue here is this contour of this other central creates an undercut because it has kind of a canted midline. So it creates a slight undercut. With that in mind, we could put a little bit of ortho wax in this embrasure to prevent the provisional from locking into the undercut and not coming off, because it has to have vertical draw. So this side was fine. This side has an undercut. A little bit of just some kind of wax in there is probably your best bet because it won't stick to the provisional material. So that's another point right there. Here we are here, filled with plumber's tape, Teflon tape. I seat my shell with my hard cast shell filled with ProTemp. Onto this, I'm letting it completely set onto the abutment. So it's going to shrink onto the abutment. We're not taking this one on and off. We're rinsing it so nothing heats up, but we're not taking it on and off. I let it completely, fully finish setting. Then we take the shell off. The provisional stays on the implant. Obviously it's going to. It's screwed onto the implant. So now I have to get the access open so I can see a little bit of my Teflon tape here. That's great. I'm going to drill it out. Here, again, comes through the palatal incisal. Now I can find my screw head and I could just unscrew this. Once this is unscrewed, because I dealt with the undercut, it should just come out vertically. And it does. So then I put it on a holder. I have the analog here. I screw it into the analog. I can look at it. That's a lot of flash. That's a lot of flash. No big deal, though. It's just because, this was just sitting over top of the whole thing. I wasn't taking it on and off. We got embrasure flash. We've got buccal and lingual flash. Not a big deal. That is a lot of flash. No big deal at all. I can trim that composite off, that flash off in probably 30 seconds. It's not going to take very long. So we trim the excess off, and then we evaluate the contours. We glaze it typically. And if you look at the contours, when I'm using an immediate provisional on an implant, an implant that's just been placed, I generally under contour the provisional. So this is somewhat under contoured because I don't want to stress the biology that's just had the implant placed by pushing on the tissue a lot. So I under contoured. So you can see it in place. It's not really that contoured yet, but it gives the patient an aesthetic provisional. We put plumber's tape back in the hole, cover it with composite resin, light cure it, and then we're done. So at that point, I was talking to the patient a few times already about maybe veneers and an equilibration. She agreed to the equilibration and some bonding and reshaping to the central and the lateral. She didn't really want veneers. That's cool. Not a big deal. Here's the way it looked at seating after the implant placement. Doesn't look bad, although the midline's off. We have to fix that with the bonding. There's some issues with the adjacent tooth. It's canted midline right now. We'll fix all of that. But the embrasure is somewhat closed, considering it's about as closed as I can make it with that crown. I have to add composite to the adjacent tooth to make this work. So there's some aesthetic things I have to do here, but you'll notice my gingival level's low. And that's because I under-contoured the provisional. Again, I remember what Dennis Tarnow told me. He said, do one miracle at a time. I did a great course with Dr. Tarnow at IDEA. One miracle at a time. Don't overstress the biology here. We have this contour pretty good. We have the implant in place. We have light occlusion on the provisional. Ideally no occlusion when it's an immediate provisional. And we're going to let this heal for a couple weeks. Probably 2 months. I tell the patient we're going to let this heal for a while, then I'll fix everything else aesthetically. We've got extra tissue. We're good. This is good deal. Everything's good. So here it is after it heals. See, it looks pretty good. We actually gained some papilla going into that black hole just because it filled in a little bit, because I didn't stress the gingival biology. But at some point, I want the gingival levels to be even. So I want to fix this. So we're going to do some aesthetic contouring plus an equilibration because she has some wear issues. And then the other thing we want to do is we want to fix the gingival levels on the implant. So you look here, gingival level's not ideal. You look here, gingival level is pretty much ideal, and I've done the bonding I wanted to do to the other central. So the question is, how did we do this? Did I do a gingivectomy, or did I do something else? I'm curious. How's everybody doing, by the way? Everybody having fun? Are we learning some things? Did we get some ideas from this, and do we like the video? What I'd like to know is, do you think I did a gingivectomy here? And we'll just see how everybody might say. Okay, so hopefully everybody is doing great. Did I do a gingivectomy? No. Good. People know what we did. So really what we did was we made the provisional contour push the gingiva apically. And that's pretty straightforward. So here's my under-contoured provisional. Here's what we want to do. We want to add contour just with flowable composite. And it's kind of a trial and error thing to get the contour all the way around the provisional of the gingival area to reflect the tissue height that you'd like. So you have to add some flowable composite, screw it back in, and take a look. And that's really the way to do it. So I add some flowable composite, I polish it a little bit, I screw it back in, and I see. If I see this one's maybe a little under-contoured still, I'll just add a little bit more there. If I find I over-contoured it, the tissue level is going to go up even higher and it'll blanch too much. So then I'll have higher gingival level on the implant than the central incisor. Right now I have lower, so it's easy to add. So that's what we do. So you look here, and look at the contour the provisional created. So we have her then test this new contoured provisional out for a month or so. You can see the contour this created. It's beautiful, beautiful. At that point, we can take the final impression in which we want to do a custom provisional or custom impression transfer. So at the end of the day, I'm going to show you my surgically guided vertical sinus lift, and I'm going to show you my custom impression transfer techniques. So we'll show you these. So again, with contour of provisionals, under contoured, you generally have a low gingival level. Ideally contoured, you have an ideal gingival level. It's a little bit of trial and error to get that contour right. You have to add some composite resin, polish it, screw it back in, and take a look at things. If you've over-contoured it by adding composite resin, what will happen is you'll have high gingival margins. They'll go too apically. And all you have to do then is just remove some of that over-contoured composite resin. It's pretty straightforward. and then you let it heal and test it. So this is after healing. It's now ready to take the final impression. With the correct final impression, with a customized impression transfer, the ceramist can make a beautiful custom abutment and custom crown. Now with the provisional, I want it screw retained, and in the posterior, I want it screw retained. In the anterior, if I have a screw retained crown that's screw retained through the incisal palatal, I generally won't make the final crown that way. We just did a case where we did a screw retained final, but I had positioned the implant more palatally. This case, because of the neurovascular bundle, I had to put the implant kind of in the middle. So we ended up with the screw hole palatal incisal. Fine for provisional, not great for final restoration. So we do a custom zirconia abutment, custom crown. This contour here matches the provisional. This contour here matches what we worked very hard to achieve on the provisional. And I'm proud to tell you, this was one time inserted. Harold took digital photos of the shades that I took and was able to nail it on the first try. It doesn't always happen that way, but with great photography, it happens more often than not. And the tissue levels look pretty darn good. I could add a little more contour to the bonding I added on this tooth because it dips a little here. But overall, it looks pretty darn good. That's being pretty fussy, I would say. And if you look at her before picture, her tooth gingiva and tooth area was gray because of the dark root was showing through the tissue. Now we have the implant platform up here and deeper where the tissue's thicker, so we don't see the gray at the margin because we used a zirconia abutment also. So this looks actually better. The implant looks better than a restored tooth. But we did it because the restored tooth had to come out. Essentially had to come out. She might have been able to try endodontic root surgery. She didn't want to go there because the chances of that working were moderately small also. So this is what it looks like. Here's a close-up of it. Again, Harold nailed this one time with decent shade photography, obviously. Here it is here. I think looks fabulous, really. So pleased with that case. This is Harold Heindel from Aesthetic Dental Creations. He did, I think, all the cases I showed tonight. I believe the cases I showed tonight, yes, everything Harold did the ceramics for. And, I'll tell you, I've had some exceptional mentors. Dr. John Coys, Dr. Frank Spear, Dr. Peter Dawson, Dr. Jimmy Eubank, Dr. Jeff Morley, Dr. Pascal Monnier, Dr. Otto Zur, Dr. Michael Picos. I could add Dr. Tarnow to this, Dr. Boozer. I've been lucky to take CE all over the world from a lot of, just exceptional teachers and dentists. And I've said this before. Steve Jobs said something that I think is brilliant. I've talked about this before. He said that you have to go out and expose yourself to the best of what others have done, and then bring some of that back and add it to what you are doing for yourself. And what I've done is I went and took a lot of CE with all of those wonderful mentors and brilliant educators, as well as a lot of other people for cosmetics, for implant dentistry, and I put it all together into something that I believe works well in an everyday general practice. And I'll tell you a bit about my personal journey, a little bit, and we'll talk about this for a minute, and then I'll answer your questions. But when I was a really young dentist, first out of dental school, I'm left-handed, so I opened my practice here in Oakville right away because it's hard to find an office you could work in when you're a left-handed dentist. But I did find one that would hire me part-time, 1 to 2 days a week. And so that was cool because I wanted to get some experience in a real dental office before I really went out and started my own practice, which was about a month and a half after I got hired. It was scheduled to open. So, I went to this practice, didn't really know a lot about different practice models. And this practice had multiple hygienists and one principal dentist. And then they wanted me to basically do, they wanted me to do the patients who needed like occlusal fillings, to be honest with you, and the patients who had what we call the provincial dental plan type of SINOT thing. If you're familiar with that in Ontario, it's basically would be like I don't know, HMO type of patients in the United States, I guess. So they wanted me to do those patients, and he had a multiple operatory practice. He had 3 operatories. They had 1 operatory for me, and then they had multiple hygienists. And so it was a big practice, really humming with a lot of patients going through. And I went in there, new graduate, and I watched him because I wasn't very busy. And I watched him, and he was seeing 3 patients at a time in his 3 operatories. So he'd start freezing on one, he'd go to the next one and drill a little bit, he'd go to the next one and put a little bit of filling in, and then he'd go over to the one that he's froze and start drilling on that one, go to the other one and put a little filling in, go to the other one and kind of take the matrix band off and finish the filling. And it was like a cycle of 3 patients at a time, day in, day out, every minute of the day. And I was like watching this and my head was spinning. I'm like, what the heck? And they were keeping track of their production. They had to meet a daily production goal, and they were, which I guess that's business, right? You have to look at your numbers. But he was grinding it out, and I looked at that after a few weeks, and I thought, oh my God, I can't do that. That'll kill me. And like I talked to him, and he didn't enjoy being a dentist. Didn't enjoy doing these cases. He'd get the odd little veneer or bridge case or crown case, and it was really a challenge to do it within an environment like that where they have them constantly booked in 3 chairs. Try doing elegant dentistry when you're booked in 3 chairs. And that led me right away as a young dentist to think to myself, I don't want to be a dentist who sees multiple patients in multiple chairs all at once, doing single tooth dentistry all day long. It made me think I want to do more comprehensive dentistry. And it really set up the practice model that I decided I want to achieve down the road. Now, being a new dentist, new graduate with a new practice, I opened from scratch. I didn't buy an office. Again, left-handed, needed to open from scratch. And I'm still here, same place as I opened 25 years ago. This led me to basically get a clear understanding of what I wanted my practice to be. But being a new grad in a new office, I couldn't be there right away. It was something that I had to visualize would be something that I could achieve in a few years, because it's unrealistic to think that you could start doing that right out of school. And here's the big problem. I didn't know how to do that kind of dentistry. I went to a couple lectures. I saw some beautiful dentistry. I remember being a young dentist and going to a lecture by Robert Nixon, who's passed away now, but was phenomenal, beautiful aesthetics. It was the nicest aesthetics I'd ever seen as a young dentist. I couldn't believe you could do dentistry like that. But what I did have, even though I couldn't believe you could do dentistry like that, it was like completely foreign to me. I said to myself that day, I said, I can do that. That is totally what I want to do. I can totally do that. I just have to figure out how and what I need to do that. And so that was really the beginning of my vision of where I want to go. And Bob Nixon talked about the AACD. I decided to join the AACD, and I immediately said, I want to be accredited in the AACD. So all of those things led me, again, to the vision of where I want my practice to go. And I had to take the CE to get there. And then I took, the programs with Dr. Coys, Dr. Spear, Dr. Dawson, Dr. Eubank, and Dr. Morley, which were the courses that I took, the hands-on small workshops that I took, that had the biggest influence on me as a young dentist. And I took those, and I took what I learned from those, and I put it together into something that works in an everyday practice. But, working in that other office made me realize I did not want to run around like that every day. And I wanted to have, joy, satisfaction. I wanted to feel achievement with the dentistry that I provide for my patients. And it made me realize I want to be a comprehensive dentist. So if this is something that you want for your practice, you want to be a comprehensive dentist, and even if you are doing comprehensive dentistry, but maybe you're not doing as much of it as you'd like, I'd suggest you do what I'm learning right now from a coaching program I'm taking with Dan Sullivan, who's an entrepreneurial coach. And in one of the books they gave us to read before the coaching program really starts, talked about, in your mind, time traveling into the future. And I realized this is what I did as a really young dentist working in that office, watching that dentist run around from place to place to place all day long. I realized I kind of I had a vision, or I created a vision of what I wanted my practice to be. And so they say at Strategic Coach, you have to have a big vision of where you will be in the future. And it doesn't necessarily have to be where you are now, but it requires your mindset to be able to go into the future and visualize where you can be, where you want to be, and don't let all the hang-ups about where you are now dictate where you're going to be in the future. And I know this is completely out of left field, away from dentistry, but it's something we need. We need to know that where we are now does not dictate where we will be. Where we are now does not dictate where we will be. And if you look at these cases, these 6 cases, the 6 patients here that I treated represented somewhere in the neighborhood of $340,000 worth of production for my dental office on 6 patients. If you look at how much production that dentist I worked for would have had to see, and how many patients he would have had to see to create $340,000 worth of production, and how many days he would have had to run from chair to chair to chair, it's pretty crazy, So if this is something you would like, if you would like to see more large cases in your dental practice, I'd like to introduce you to my occlusion design program. And if you have a really big vision for your future, for where you want to go with your dental practice, if you're interested in this kind of dentistry and treating these kind of cases, even if you're mostly interested in just, 4 to 6 unit to 8 unit veneer cases, occlusion design is specifically for you.
And it's really my flagship online training and coaching program. I've designed the curriculum to teach general dentists the systems to improve your restorative dentistry and manage more complex wear, aesthetic, and full mouth rehabilitation patients. And as I said, this is an online curriculum. There's no need to travel. You can watch this on your computer, on your iPhone, on your Android phone, on your tablet, on your laptop, anywhere where you can find an internet connection. You can connect and enjoy the online curriculum and learn from the online curriculum. And this is important in these days of self-isolation. With this global COVID-19 pandemic, I found myself in self-isolation. We went out to Turks and Caicos for a family vacation before the pandemic really started and escalated. And suddenly the government of Canada is advising all Canadians to come home. So I had to rebook my return flight, come home early. Then you find yourself in 14 days of self-isolation. My practice is closed. So, I could either spend all my time watching Netflix, or I can improve kind of my online learning. And I think that a lot of us in this situation where we're either practicing a lot of social distancing or our practices are closed, it's a good opportunity for some online learning. So that's where this fits in very nicely. There's no travel required. This is a comprehensive online training for restorative dentistry, smile design, and rehabilitation cases from the comfort of your home or an office. And recognizing that this is a pretty uncertain time with a lot of us having our offices closed, I've decided to recreate the membership to have a occlusion design digital membership only offer for all of you. And this saves $1,000 from my usual occlusion design membership. So my usual membership that you would see if you had watched this webinar even yesterday is one payment of $29.97 or 4 monthly payments of $8.47. And we've changed this to a digital only membership where we don't have to mail you a bonus package. And this is a less expensive version. So it's $1,000 off. It's now one payment of $19.97 or 3 monthly payments of $6.95. And with this, you're getting a complete online library of CE courses. So let me share with you the different programs you're going to receive with this Occlusion Design digital membership. You're going to receive Occlusion Design, of course. You'll also receive my Functional Occlusion online seminar recordings. So that's the complete recordings from my 2-day seminar, Functional Occlusion Online. You'll receive the complete recordings from my 2-day seminar, Occlusion Design Live Toronto, and the Occlusion Design Live Montreal seminar. You'll receive the Rehabilitation Systems seminar recordings. You'll receive our portal for Occlusion Design team training, where my assistant Amanda was teaching monthly coaching webinars for team members. And if you join during this webinar, you're going to receive my full mouth rehabilitation case studies seminar recordings, which was a 2-day seminar I recently completed teaching full mouth rehabilitation case studies, a number of different case studies from A to Z. And this was a really popular seminar, 2-day seminar. You have the complete recordings here in your portal. Let's look at Occlusion Design first, quickly. And if you look at Occlusion Design, and with these portals, with this membership, you've got the navigation over here on the left-hand side. You have Occlusion Design main course, and it's a modulated course, modules 1 to 6. And inside each module are the module videos. And these are detailed videos. We have the introductory presentation. So module 1 is comprehensive diagnostic records. We have the introductory lecture, which is about, in this case, 2.5 hours. And underneath each video, you have a description. We're just working on new descriptions at the moment, and module 1 is all completed. You have an area where you can ask questions, and I'll go in and answer. You have downloads for each module, and then, of course, the module videos. If you go back to module 1, we've got the main lecture. We have video for pouring study models. We have some videos for impression taking techniques. That's part of team training as well, but also will be great for you to reference right here in module 1. We have diagnostic wax up. We have mounting study models, the introduction and protocol, and the demonstration. We have model analysis. We have a lecture about identifying patterns of wear that you would look at as part of your model and photographic analysis. We have a demonstration of the functional analysis, demonstration of using the leaf gauge, demonstration of the Lucia jig, Coy's deprogrammer, face bow, another demonstration of mounting models on the articulator, and then the module 1 webinar, which includes basically a couple of additional videos showing and demonstrating using the leaf gauge technique for CR. So this is a very comprehensive module about comprehensive diagnostic records. And then module 2 is risk assessment for complex cases. With risk assessment, you get our risk assessment download that you can use in your practice. This is a very detailed training as well, and it will help you really identify the risk associated with treating some of these patients, especially a high-risk wear patient. And this is something that people struggle with, is the wear patients in their practice. So this will help you identify and also communicate with the wear patients, because the wear patients, they need to understand what parts of their treatment and their dentition are at risk for treatment, without treatment, and what's at risk if they do nothing. So this is a good module to help with risk assessment. Module 3 is treatment planning complex cases. So this follows very detailed training about treatment planning the wear patients again, but also treatment planning aesthetics for implants and teeth. And basically, again, altering the vertical dimension, for example. It teaches in detail about force management. Force management is a big part of treatment planning. And then taking the treatment plan and transferring that to the diagnostic wax up is another important aspect of all of this. So that's here as well. Module 4, let's go back to the main course, is pre-treatment case presentation. This is really good because it's really going to help with your restorative dentistry, because we talk about rebuilding the structurally compromised tooth, and we're talking about posts, core buildups, post and cores, etc. I have a core buildup technique that I've been using for 25 years. And if I happen to be cutting off an old crown from the 90s and they had this core buildup technique, it's one of my cases, the cores look incredibly good. So say we have an old metal ceramic crown and some of the veneering porcelain broke and I cut off the crown to replace it. The cores are unbelievable, even 25 years ago from the 90s. It's really quite stunning. So that's Module 3 at the beginning is rebuilding structurally compromised teeth. Then it goes into altering the gingival levels around teeth and implants. And it goes into teaching you about equilibration. So we have trial equilibration plus the actual equilibration on patients with video showing the actual treatment on patients, both kind of operatory views and microscope views. So it helps you really see that particular procedure in detail. And we showed 2 different cases for this as well with the equilibration. So this is, equilibration is really good for a number of things. For veneer cases, there are a lot of veneer cases that can benefit from an equilibration if they have a slide that slides the mandible into the front teeth. It's also good to have equilibration skills to equilibrate provisionals on a full mouth rehabilitation type of case. And it's also good for equilibrating bite splints. So the principles are almost the same between all of these things. Once you have the principles down, you could really figure it out and use it easily, because I use a leaf gauge technique, and the leaf gauge is exceptionally good for equilibrating teeth, equilibrating provisionals, and even equilibrating a CR type of bite splint. So that's Module 4. Now to Module 5, we have preparation techniques. So this is teaching you about preparation techniques for onlays, veneers, crowns, all of these types of different restorations. It also teaches you about provisional techniques, and it teaches you about different types of preparation techniques, whether it be the diagnostic matrix technique where you make a mock-up and cut depth guides into the mock-up. There's just a lot of different detailed techniques in this module, as well as different veneer provisional techniques also. So this is a great module, very detailed number of case studies. Then Module 6 is bonding cases, but it's also precision restorative records. So the records that you need when you've either prepared a whole arch of teeth or the whole mouth of teeth. There's specific records that we use both in the dental practice and in the lab. So in this lecture, my ceramist joined me, Harold Heindel, and we spoke about lab restorative records and, in the chair restorative records and how they work together. So it's a very nice lecture, and I think you'll enjoy that. And there's also with this a step-by-step protocol that you could download for restorative records that will help you. And it's kind of like a checklist. And then I share a number of different bonding cases. I share this case, which is bonding in a veneer case. It's now about a 15-year-old veneer case, which looks exceptionally good still. But this is video I did basically 15 years ago with my microscope, with my Zeiss microscope, and made this video series. And I know that this works well because the case still looks great 15 years later. And I've posted that case post-op, longer-term post-ops to the Facebook group. And then there's this case, which is a full upper arch that I treated on another dentist. In this case, because I was treating a dentist, we were able to videotape the whole thing in detail, start to finish, even the bite records. So this was the bite record stage, but we also videotaped the bonding in of the upper arch. Again, step by step, operatory views as well as views right in the microscope that you can see really close up exactly what I'm doing. Also, you're seeing where people can ask questions and I'll go in and answer them. This video series was really unique because, again, I was treating a dentist. Because I was treating a dentist, I was able to speak freely as I was treating her and explain what I was doing. I wouldn't feel comfortable speaking about every technical aspect of what I'm doing when I'm treating a patient because it might freak them out a little bit. But this being a dentist, I was able to speak openly, freely, and talk about what I was doing, and it worked out really nicely. And if you look at the videos, you have full control with the videos. You can forward or reverse. You can play them. You could stop and reverse. You can make them full screen. They look very good full screen. It's just a really nice system to consume online content and online CE. So that's module 6. After the core modules, we have applied occlusion design, which shows 4 different full mouth cases and details start to finish. So it's the entire case start to finish using the systems from the core 6 modules. So those are more case studies that you can look at. We also have the coaching webinars. So we have, I think, about 7 years worth of coaching webinars here. The coaching webinars, again, show the case studies that I'm doing in my practice right that month. Once again, these can be made full screen. And let me just turn down the volume there. So with the coaching webinars, I share cases that I'm working on that month in my practice.
Right.
And if you look, they can be made full screen. Very, very high def videos.
Turn down the RPMs on my
So you can see these videos are very detailed. So what we do in the coaching webinars is I present one of the cases that I'm working on in my practice. I present that for probably the first hour and a half of the webinar. Then I answer questions. And then we look at members' cases. So we have members basically asking questions sometimes. So we answer those, but we also have members with their specific cases that they submit ahead of time, and we treatment plan and talk about their cases and troubleshoot their cases. So we look at members' cases each and every month. It's one of the fun things about the monthly coaching webinars. And if you're a member, you can submit cases every month or submit the same case sequentially as you're going through and working on the case, and I can help you with your case. So that's why this is an online curriculum, but it's also an online coaching program because I'm helping members with their cases each and every month. And the nice thing is you're seeing new cases that I teach with that I've treated in my practice that month. So you're seeing new content each and every month with this program. Each and every month you're seeing new content. So that's what the coaching webinars. We also have a digital photography module. With the digital photography module, you see exactly how I take photos, and you'll see how I edit the photos, but you'll also see exactly step by step how I take the photos in the photo series that we use for communicating what we do for our patients. There's a bonus area where we have some of our guest speaker seminar recordings. So we have Simplifying Bone Augmentation by Dr. Naheed Mohammed. This was a 3-hour webinar by Dr. Naheed Mohammed showing some detailed bone augmentation techniques. We have PDFs from Dr. Monnier. These are a series of PDFs from Dr. Pascal Monnier about techniques that he taught during his online seminar. We have a online webinar from Dr. Michael Picos, crestal sinus grafting using osteodensification burrs. Excellent. Another 3-hour presentation. We have another 3-hour presentation on composite resins by Dr. Bob Margis. Practical tips and tricks for making your composite resins better. So these are special series seminars that we basically have for our members on a regular basis. I'm in the process now, since a lot of us have to stay home at this time. So I'm looking for some speakers to add some additional special series members presentations. I put a couple of emails out today. I expect I'll have a couple of speakers booked for over the next couple of weeks that we can learn from as we're going through and, learning this online platform, all this online content that I have for you. So I'm planning to have some additional speakers as this pandemic is going on, because a lot of them are available right now. Most of the dental meetings have been canceled and probably will be canceled for the next 3 to 6 months. And quite frankly, I wonder if I want to go to a huge dental meeting anymore after this, at least for the next little while. I'd probably want to wait till later in the year. So this online environment, I think, can be very good for us to learn. So here's functional occlusion seminar recordings. Again, the portals are all similar. This one has day 1 and day 2, plus a CE test. There's CE tests for each module of occlusion design as well, by the way. And then occlusion design module 2, or functional occlusion online day 2, sorry. The manual, so there's a manual you can download. There's a bunch of different downloads here, and there's some bonus videos. So this is another nice platform of training in your portal. We've got Occlusion Design Live Toronto and Montreal. Those are 2-day seminars. We've got the systems training, which was a nice little lecture that I did, an 8-part lecture about the different systems that I use in occlusion design. It's not detailed like the core modules, but it's a good overview. You might enjoy watching that. We also have team training. With this, you can, if your team members are basically looking for something to do over the next little while, this can be really good for them, because basically we're going through and we're teaching. Basically, I'm not teaching it. My assistant, Amanda, is teaching different aspects of work that the team members do so that they can learn how we do it in our practice. So there's clinical photography. There's 2 webinars on clinical photography. There was mounting models on the articulator. I believe there was 2 webinars for that. There was setting up a procedure manual and restorative procedure setups. So it was basically setups of different systematic setups of kits that you would use for different procedures. And Amanda gave our kits that we use as PDF handouts for your assistants so that they can reference that and all the materials and supplies that we use. And then there was basically a webinar on using Optrogate and Isolite, which I think are really excellent tools, but some assistants struggle to put them in. And then there were 2 webinars on Rubber Dam. Again, another excellent tool that some team members struggle to place. I don't place the Rubber Dam in my practice, but I use a Rubber Dam on almost everything. Amanda places the Rubber Dam. So she's teaching how to do this with, again, videos on all of these. We shot separate videos for most of these webinars. And then there was a webinar on impression taking, actually 2 on impression taking. Excellent trainings on impression taking. And then there was a recent webinar on fabricating putty indexes and putties and stents. And there will be another team training webinar in April that will teach the different hard cast plus copyplast stents that we make and use for rehab cases, veneers, etc. The type of materials that I use to create provisionals, mock-ups, and just to check the depth of preparation. Now, when you join today, we've got this extra bonus, which is Full Mouth Rehabilitation Case Studies Seminar, which is day 1 and day 2. So here it is. This is a full 2-day seminar about full mouth rehabilitation cases in lots of detail. And again, you can make it full screen. You could watch it smaller, but you could also make it full screen. You could forward and rewind. It's really a nice seminar to be able to look at these full mouth cases. So this is day 1. And then we have day 2. And so with day 2, I looked at this really complex full mouth implant plus tooth rehabilitation. We looked at precision restorative records. Again, Harold joined me to talk about that particular part of the day 2 presentation, kind of an updated presentation with Harold and I. And then we looked at which arch do you complete first. This was detailed part of day 2. When you're doing a full arch case, a full mouth case, a lot of full mouth cases, we have to decide which arch to complete first. Usually I don't complete it the full mouth at once. I usually select an arch to complete first and then test the completed arch against the plastic teeth, the plastic provisional arch, make any changes to the plastic provisional arch to optimize the case, and then finish the second arch. But there's specific guidelines here about which way to pick that. And then, day 1, the second half of day 1 was all on phasing cases. So it was treating cases with partial rehab in porcelain, the rest of the rehab in composite resin, because some cases are better treated not full mouth porcelain, but maybe partial porcelain, partial composite resin, because basically not everybody can afford the full mouth rehabilitation all at once. And that might be the case for the next year. So we might be having to phase a number of cases over the next couple of years, even depending on the economy. So phasing could become a huge part of what we do for helping patients, because some patients, they need their vertical dimension altered to be able to create room for restorative material, but they might not be able to afford a full mouth of porcelain restoration. So this phasing section of this 2-day seminar, I think, is very important. So that's another thing that you get. You'll receive that bonus if you join today during this webinar. So that's basically the portal. Here is the order form, very simple. 1 payment of $19.97 or 6 monthly payments of $6.95. So that would be a payment of $6.95, then 30 days later, the next payment, then 30 days after that, the next payment. And basically, this is a 1-year membership. You'll receive access to the whole portal for 1 year and 12 monthly coaching webinars. After a year, you'll have the option to renew your membership for 1 payment of $997, or I think it's 3 payments of $300 and something dollars. I'm not sure the exact amount. It might be $350. But 3 equal payments of around $350 or 1 payment of $997. That's the renewal. And many people renew because we have special series webinars or seminars every year, different speakers, guest speakers, and people also like the full monthly coaching webinar that I present. And, there's a lot of content here in this portal. It gives you more time to go through it or go through it again. A lot of people like to go through specific parts a second or third time before they do those procedures. So this is your library. This is the order form. Once again, order today and you'll receive full mouth rehabilitation case studies as an additional bonus. And just to review or recap what you'll receive with this, you're receiving a new online portal with occlusion design and 5 different seminar replay video membership sites, including full mouth rehabilitation case studies replay video portal for that particular seminar. The webinar replay video from Dr. Robert Margis, practical tips and tricks for making your composite resins better. The webinar replay video from Dr. Michael Picos, crestal sinus grafting using osseodensification burrs. The webinar replay video from Dr. Naheed Mohammed, simplifying bone augmentation through key principles of regeneration. The Functional Occlusion Online Seminar Recordings Portal, the Occlusion Design Live Toronto Seminar Recordings Portal, the Rehabilitation Systems Seminar Recordings Portal, also the Occlusion Design Live Montreal Seminar Recordings Portal, the Porcelain Veneer Before and After Case JPEG downloads. So these are some before and after case photos that are available as downloads that you can download and use in your practice. What some people have done is they've basically printed them, put them up on the walls of the practice, and people ask them about porcelain veneers based on these photos. And then the Smile Makeover PDF ebook as well as the occlusion design team training. We basically will send your team members, once you register them, access to a portal which only has that. They don't receive access to the whole thing like you do, but they do receive access to a portal that just has occlusion design team training. And you'll also be invited to join the occlusion design Facebook group. So let me just share with you these downloads. So if you go to the welcome section, so your occlusion design main course, welcome section, you have the before and after case photo package. These are the veneers. They're available as PNG or JPEGs. And then if you go and you just click to download them, and then if you go here, the Smile Makeover PDF book, you just click to download that as well. And these are designed to be used in your practice for basically internal marketing. They're not designed to be used externally. This PDF book is not designed to be printed. It's designed just to show on, say, an iPad or a computer. These JPEGs are designed to be printed. So these are designed to be printed. The PDF ebook is designed basically to show on a computer. So let me show you these. Yeah, this is one of the before and after JPEGs. So here's this one. That's this case. I have 3 versions of it. And lower veneers are really powerful in our practices. So one of them says, ask us about fixing your tooth wear. That gets people asking about this all the time. And then one of them is just the case, but I like the ask us about fixing your tooth wear the best. The other one is ask us about porcelain veneers. That one's not bad either. But I think the one that really I think is the most powerful is ask us about fixing your tooth wear. So you can print these, put them up in the walls of your practice, or show them on a device also, like an iPad or your office computers. And then there's this Smile Makeover PDF ebook. Again, this is something that you can scroll through and show patients on it's really good on an iPad, actually. I think that's the best application. So there's veneer cases. There's dental implant cases. There's porcelain crown and bridges. And there's some full mouth rehabilitation cases. So it's a nice little ebook just to show some different cases and help you with your case acceptance as you're kind of getting going with doing this kind of dentistry. Once we get rolling again, I have full confidence that once all of this blows over, we're going to be doing really, really well again because, there's always a need for this kind of dentistry. We might need to be able to phase some cases from an economics perspective. That's where the phasing cases part of the full mouth rehabilitation case studies really will help us. And I'll be featuring that more on monthly webinars because I'll probably have to do some of that myself, more than I have had to do in the last few years. So we have to be able to adapt to the times. And part of me adapting to the times is offering this as a digital package without as high a investment. So I'm lowering the investment cost to try and make this accessible to more of you out there so that you can join and use this time productively. So one payment of $19.97, that's USD, or 3 payments of $6.95. So with $6.95, you could really get started with all of this. We have our monthly coaching webinars. We have a special series seminar coming up. I'm just waiting to announce the presenter once I confirm it. But I have a couple of offers out there, and we'll see which person we use as our first special series seminar. So again, use this time that we have now productively. If you can, I think that this will be really helpful for all of us. This was my regular occlusion design membership fee. And we still have people joining at this fee, even today. But I was just giving it a lot of thought last night. And I thought, to make this available to more people in this time of this COVID-19 pandemic, I just want to make it better, easier, more accessible to more of us dentists who are not in the practices right now and do have time to learn this material.
So I've made it a different price point, price structure. We don't have to mail you anything with this, so that's kind of easier for us as well. It's all online delivery. And I think it's just going to make it easier for all of us that are having our practices closed for, who knows how long, 3 to 5, 6 weeks. And you'll be able to use this time productively. And I just want to contribute to all of your CE in an online environment because, again, we're not going to have any dental meetings for a little while. I was looking at something in the Globe and Mail, which is Canada's national newspaper, online, and they said that somebody got infected or went into the PDC, the Pacific Dental Congress, which is a huge dental meeting out in Vancouver, with COVID-19. And then they found that was the source person, 4 or 5 people within a couple of days who were also at that meeting ended up with COVID-19. And they've recommended everybody, 10 or 15,000 people that went to this meeting, to now self-isolate, which is pretty crazy. So I think we'll still have some small courses, maybe in a couple of months, some small in-person courses. But I think these big dental meetings might be done for the rest of 2020. So this is a good opportunity to take the time and learn online. And that's why I've tried to restructure this so it's more accessible to more of you all around the world. So hopefully you can take advantage of this. If not, I do have my YouTube channel with a few different videos on that. Nothing like what's available in the library of courses that I've put together, but it will give you some additional training. And if you can't do it, this week, hopefully at some point in the future, we can connect and you could join and we'll connect on our monthly coaching webinars and I'll be able to help you with pending cases you have thought about using and doing in your practice. So thank you very much. For this webinar, if you have any questions, if you want to type them in, let me know the questions that you have, and I'm going to create some new YouTube videos based on the questions. So I'll try and answer your questions through a YouTube video format. So I have my full studio to create YouTube videos here in the basement of my house. I'm at my house self-isolating, but I have lots of time to be productive. I'm going to create a whole new series of YouTube videos. So just let me know whatever questions you have, and I'll try and pick the most common questions and answer them with new YouTube videos in the next week even. I'll try and get onto these really quickly. So thank you very much for attending, and I hope this helped you. I hope you're able to join. If you can't join, that's cool. I totally understand. Check out my YouTube videos, maybe some of my other free webinars, and hopefully we'll be able to connect with you being a member at some point in the future. So thank you very much, and we'll talk to you soon. Take care.